Good evening, everyone, and thank you for joining us. Welcome to tonight's clinical webcast, Axial Length Unlocked, a clinician's toolkit for myopia control with the OCULUS Myopia Master. Throughout the session, we encourage you to participate by submitting your questions in the text box on your GoToWebinar screen. Feel free to enter your questions at any time. We will address them during the Q&A session at the end of tonight's webcast. We are honored to introduce our expert speakers, Dr. Matthew Martin and Dr. Sheila Morrison. Dr. Martin, we'd love for you to kick us off.
Excellent. Thank you for joining us. I am so very excited, and I know Dr. Morrison is as well. So let's jump right to it. Quick little information about me. I am a private practice owner. I've been involved with orthokeratology and myopia control since 2001. I got my fellowship in the Ortho-K Academy in 2005. I've done a fair amount of speaking, and after 23 years of doing Ortho-K and myopia control, I am still super excited about it. So really excited to share our experiences with the Myopia Master, and I'm just really stoked that you guys are joining us. Dr. Morrison.
And I'm Sheila. So again, can't echo. I love getting together. Actually, I had the pleasure of meeting Dr. Martin at the GSLS, and we kicked off our relationship leading into this webinar by working on a workshop. So it's been a blast to get to know you, and I'm very happy to be here too. I practice in Canada, so I'm bringing another flavor. My background, I trained at Pacific. That's where I did my residency and master's degree in contact lensy kind of stuff. Spent a little time teaching at the University of Houston, and now I returned home. Our practice is called Mission Eye Care Center for Dry Eye and Corneal Disease. I'm a supervisor for a contact lens resident and adjunct faculty for Oklahoma. I do fun stuff too, just, like to lecture, like to get out and meet folks and help co-host a podcast. And a large part of our practice is we have what's called the Myopia Academy. It's a section within our practice that is devoted all to myopia management, and it's very full scope, similar to Dr. Martin. And so we're pretty excited to team up here to share some of the stuff that we've picked up along the way. So yeah, here we are.
All right. So let's get started. This is your slide. Sheila, do you want to take us through this one?
Yeah, it's just, it's kind of a fun little thing, the definition of what is a master. So having or showing a very great skill or proficiency or acquiring complete knowledge. And I thought it was fitting to kick off with something like this just because the equipment that we're wanting to really highlight and share of how we use in our clinical practices is called the Myopia Master. And truly, it is a piece of equipment that has elevated our office, not only, starting off at a ground level measuring axial length, but to the higher level where we've become a master of our field. And as we flip over onto the next slide, we can move forward. Yeah, so axial length basics I wanted to make sure to include. And basically for those of you that need the cobwebs dusted off just a little bit, when we're born, the eyeball length is, about 16 millimeters. And at full growth as an adult with an emmetropic eye, we're aiming for around 23.5 millimeters. So anything longer than that is considered to be longer than our emmetropic eye. Now, there are different ways that we measure, all kinds of innovations, but generally there are two different sort of types of tools that we can use to measure the length of the eye. So we have A-scans and biometry. The Myopia Master is a biometer. Typically at our office, we measure every 3 to 12 months, depending on the case. Dr. Martin, are you measuring axial length in your practice? I know that you are, because we're talking about our shared love for this equipment in this webinar. How often are you measuring people and when?
Yeah, so I'm glad you bring this up. So we are pretty aggressive with our taking of axial length measurement, and the Myopia Master has been such a big part of that. So in our office, when we're working with all patients under the age of 18, we're collecting axial length measurement. And then specifically for our patients who are in our myopia management programs, we're measuring them 3 or 4 times a year. And it's amazing the data that you find and the changes that you can find when you are paying attention to that. So our frequency is quite high. Sheila?
Yep, love. Yep, you can move on. Yep.
All right, sorry about that.
And for everybody out there too, so just to give a little insight, Dr. Martin, I can see Dr. Martin, but he can't see me. So when I give him a wink that it's time to advance, he's just in his own cloud.
Yes. Thank you so much, everyone. So what's cool about the Myopia Master, and the reason why it's been such an amazing instrument for our office, is it was developed specifically for myopia management. So it's not a tool that was developed for cataract surgery, for example. It does axial length measurements. It does keratometry. It has a pretty decent autorefractor in there. What I really like are the progress reports, and where the magic is at is the risk factor analysis reports, which frankly, I think are easily the best feature of the instrument. It is an instrument that really opens the door to a ton of conversations, which we'll be talking about later in our slides. But I think it's also pretty great because it really truly is a combination instrument, and it fills a lot of roles that are needed in the office. So I think this is a great slide. And the reason I think this is a great slide is because I talked to so many doctors who want to do myopia management, but they just don't know how to start the conversation. And Wayne Gretzky said, you miss 100% of the shots you don't take. And I think that is such an incredible take-home message, because if you purchase an item like the Myopia Master and implement it in your office and start actively scanning these young people, you're going to see all kinds of stuff that you didn't know was there. And it's going to open the door to a lot of opportunities to really grow your practice and to really be involved in helping these children to have better outcomes.
See, I thought you put the slide in just because you love hockey as much as Canadians do.
I do love hockey because I am going to see the Wings tomorrow night, so I'm pretty stoked about that.
And I won't
So
mention the Canadian American game from this week.
that's okay. I take no offense. You guys whooped us, and I'm glad you did. So this is a absolutely beautiful watch. I think this is a fun slide too, because this watch is gorgeous. I went through a period where I was really into watches, and this Breitling is just fantastic. But ultimately, what does this watch do? Honestly, it really just tells time. So I think one of the things that's amazing about the Myopia Master is it does a lot of really complicated measuring. It does amazing stuff with showing us progress, and we'll get into some of that later. But honestly, it really makes it easy for me. It simplifies the conversation with patients when I can say, we're really talking about axial length. I've gotten now, Sheila, and I think you may or may not agree with me here, I've gotten now where I talk more about axial length measurement than I ever talk about prescription when it comes to myopia management.
I agree.
All right, so do you want to talk about this slide, or would you like me to?
Sure, I think so. This is actually your slide, but essentially, what this process looks like for, I think, for both of us is utilizing technology to really elevate our clinical flow and really having this structure. And I love the structure that you put in this slide because I believe that it really matches exactly how we do it in our office as well, where we're not just kind of picking random flows and picking random things to do in the clinic. It's a specific process where of measurement, data analysis, looking at risk. This unit creates a myopia report and ultimately results in growth control. So now some of the things that have been changing in the myopia world, it's really kind of cool. You know, in our next slide, you'll see that the future is so bright. And you know, some of the things that I think both of us are very excited for, and I know the American Academy, there's a lot of really cool things that are always happening in CE and always happening in social media. But some of the kind of buzz things that go on, new contact lens designs are very exciting. You know, advanced pharmaceutical treatments are exciting in myopia control. Looking at environmental modifications. So in the whole big picture of myopia, you know, light levels is actually, it's kind of cool. There was a study that I was reading about, I don't know if you've heard about these yet, is in some countries, folks are actually looking at ergonomics in school as an avenue to reshape what are we doing in the environment that can be modified to better serve children and their development as far as prevention of myopic progression. Now, AI and data analysis is something that is also very exciting in all areas of eye care, actually all areas of medicine, not just eye care. So I have to ask you, you know, are you using artificial intelligence in your practice, Dr. Martin?
Well, this is interesting because you and I had briefly talked about this before. If you're using a device like the Myopia Master, you're absolutely involved with artificial intelligence, at least from the perspective of we're looking at algorithms, we're looking at data analysis, we're looking at risk factors. So really, honestly, just one area alone would be the Myopia Master. But honestly, AI and algorithmic analysis and data analysis is so much a part of our lives. We sometimes don't even know it's happening.
100%. And it's really, you look at anyone that uses a smartphone, uses anything. If you pull up the definition of AI 2 slides down, it really enables us to, understand and translate information in ways that are much faster than we ever could before. And one of the beautiful things about this and utilizing technology such as, this kind of data analysis that's provided by risk assessments in Myopia Master is what that does for me is frees me up, and my intellect and my time is not spent so much on drawing out these things and I used to actually plug in data into an Excel sheet that we made by hand. And do you know how much time that takes? That is time away from my patient. That is time away from all the things that I can do with personality to share, connect with patients. And so what it does is we don't shy away from the use of AI. It can be a little bit intimidating, but embracing it has allowed me to really spend more time with my patients at the end of the day.
And that is 100% true. And I myself have seen that as well. So it used to be I would measure the axial length measurement. I would
Yeah.
look at the figures, I'd subtract it, I'd divide by 12, or hold
Yeah.
on, they haven't been in 9 months. So I really have to technically divide by 9. But maybe that's wrong too. And then I'm trying to figure out how to tell the patient exactly how much growth we've experienced in the last year mathematically. And it was just altogether too difficult to achieve in an efficient manner.
Totally. Hey, I have another question for you.
Yeah.
Well, would you say in your practice, do genetics matter? So when you're debating, now we're talking about risk assessment, from your experience, at what point do you look at genetics these days? Is that something that matters to you in your risk assessment?
Yeah, I think it absolutely does. And I think that's probably true of almost everyone listening, even if you're not someone who has taken an active role in measuring axial length or paying attention. You know that if you have a set of parents who are -9, you know that that child has a high probability of being at least a -6 themselves. So you know genetics are going to factor into it, as well as ethnicity factors into it as well. I know I have patients of different ethnicity who have much different growth rates. And I think that's reflected, I don't think, I know that's reflected in a lot of studies as well. What's your,
Agreed. Totally. I mean, it's definitely an assess. Let's hit the other risk factors. So, taking a look at some of the other risk factors, just to kind of give a full picture for our listeners, because we know that some of you have been doing a lot in your practice for many years, looking at myopia and myopia management. Some of our listeners, some of you are probably here because you're wanting to get into it maybe in the earlier stages of your practice. And so for full circle, Dr. Martin, I wanted to make sure to include informative kind of information so that you can just understand all the risk factors. So, the myopic parents, that hits on genetics. Outdoor time has been shown to be a risk. Mirror work has been shown, but some of the ones that I really want to highlight, so age of myopia onset. So that is something that in the latest literature, newer studies are showing that the number one risk factor and one of the most important things for us to look at is how far off is a child from their age norm, and is it at a very young age or at an earlier or a later age? Because the younger they are and it's intuitive, it makes sense that if they start early, they're more likely to progress to a level that could be more problematic the older that they get. And then another risk factor, and I just had one in my clinic today, literally just 10 minutes before we hopped on here. Remember binocular vision disorders, and remember that exo, especially intermittent exotropia, can be considered a risk factor, or not be considered, it is one. We do see kids in the clinic, and I have a kid, that I, see very often. Exo kids tend to have faster rates of myopic progression. One of the other things that happens too in kids that have an eye that wants to turn out is they may end up with lesser quality vision in the eye that does. And I've seen kids that have a exo progress faster in that eye, and largely because the signal that they're getting inside is not as, as clear, as good as the fellow eye. So these are some just common risk factors that we see. Now, when we assess risk, I want to just remind and highlight again that in our next slide, just a couple of key points from a study looking at axial length. So I wanted to highlight, when we're looking at axial length, are we looking at percentages? Are we looking at an absolute rate of change? How do you interpret data when you look at axial length?
Okay, so you're looking for the next slide, is that correct?
Yeah, we could talk about it here though, because this is an important thing. So when you are talking, let me be more clear, and without seeing my face, all my questions to you.
Yes, thank you so
Yeah.
much. I appreciate your understanding.
Yeah. So as far as when you are looking at a rate of change of axial length in the clinic, do you talk about that change in a percentage of change to parents, or do you talk about it in an absolute number?
Yeah, I'm glad you asked that question because I actually do both. I talk about how quickly the child is changing. Are they zero point 0.2 millimeters a year, 0.3 millimeters a year, or more? I talk about how that relates to their age. And then, sort of 26 millimeters or more is sort of my point where I start to say to the parent, look, we really need to keep this child under 26 millimeters. Is it an absolute number? Not necessarily, but it is a number beyond which we see the probability of problems going up significantly. So I actually do kind of a combination of things. I talk about rate of change and how much that's going to factor. I talk about the age, and then I often will talk to parents and be like, we really want to put the brakes on your child. They've got a 25.5 millimeter eye already. What can we do to absolutely slow it down? Because they've grown as far as they have, because we're as late in the game as we are, do we need to do a combination of two different methodologies, maybe ortho-K and low-dose atropine, maybe peripheral defocus lenses like the MiSight with atropine? I mean, I think there is definite value in being aware of not only rate of change, but also once we get above a certain amount, the risks go up significantly.
Love.
Is that
Hey,
like as
that's a perfect answer. And that leads right into the next slide. And get this, you guys, this is where we elevate our practice because, and Dr. Martin and I have had conversations about this. And so I know that we're on the same page. Here's a study that was put out. And this is, there's a lot of things that have gone into these studies. This is not a new study, but basically some of the things that we've learned over time through literature is that the actual fastest rate of change in refractive error happens a year before the onset of myopia. So that is a really important factor when we're elevating our practices. So Dr. Martin and I are both measuring axial length on majority of the kids in our practices. We're both measuring at intervals that is appropriate for kind of how fast the progression rate has been or kind of what the risk is. And now at this modern day of 2025, we're pulling from some of these studies, knowing that the actual fastest rate of change happens right before kids become myopic. So that poses a question to us of a further utility for the axial length measurement, in that if we're able to look at children and look at their rate of change, or not rate of change, how much are they changing per year, even starting at a younger age before they become myopic, that allows us to have a clue about how likely they are to progress. So for example, we'll measure a 4 or 5-year-old who has risk factors. They're not myopic yet. They're at their normal age where they should be. And I've got a slide shortly after this to show what the normative numbers should be. But if we see a kid who's changing rapidly more than they should be for their age norm at a young age before they become myopic, it's kind of like the writing's on the wall and we know what's about to happen. Now, that leads us into the next question about, should we be treating pre-myopia? And so that is my next question that I'd like to hear your thoughts, Dr. Martin. When we see a kid who has risk factors in our clinic, or if you can see that there's a child that has a prescription that's outside of where it should be for their age norm, do you believe that it's important, or should we not be pre-treating?
Yeah, so I think we should be pre-treating. It's a hard sell for some parents. And I think that's definitely something we have to have a conversation about. When you have a child that is not yet myopic, it's very difficult to get the parent on board with wanting to treat that child. But the Myopia Master has saved the situation several times for me because I
Totally.
can say, your child's not myopic. They've got every indication they're going to be myopic. Let's see them in 90 days for follow
Mhm.
up. Let me see them in 4 months or 6 months, even at the outside. Because oftentimes I can have that child come in and I can take a look at those axial length measurements and say, look, here's where our growth rate is at. Here's where it's going. You know,
Exactly.
there's an old saying that there's not a storm cloud in the sky, but I can still smell the rain, right?
Love
So
that.
something's going to happen, right? And so I think it gives us the ability to show that parent we're going to have a problem. Let's get ahead of it.
I love that. And parents understand normative data. So, like, you take your kid to the pediatrician and they're talking about where do they rank on their kind of growth curve, or where are they on their, their percentile for height. And that is something that is now readily available through evidence base and studies where we can actually explain to a parent. So, if I have a child who has, maybe a plus 50 or something like that at 4 years old, but their eye is longer, I'm much more likely to consider pre-treating versus a child who has a really, really short eyeball and they haven't quite hit it yet. I may be less likely to treat them ahead of time. So what is the normative data? In the next slide, here's a couple of figures. So if you kind of flip forward one more, as far as refractive age norm, my magic number when I think about what is normal, what is not, is I'm looking at a 6-year-old being about a plus 75. Any child who's around 6 years old that's less than a plus 75, I'm getting really suspicious. Now we can also look at what is normative for axial length. And this is where considering risk factors and using a tool like the Myopia Master to actually measure with precision is really, really useful, because we can look and see, well, are they within their age norm for eye length at 6 years old? Much less likely for me to pre-treat, even if the parents are myopic. If they're outside of their axial length measurement for their age norm, much more likely to pre-treat. And you wouldn't know this, you wouldn't be able to share from, I guess, an evidence-based perspective of why we make that recommendation unless we have the data. And that's where the information is just so valuable. Now, as far as what is the latest and greatest with the technology, I want to share a slide that highlights some of the really cool things that are kind of available in the growth control module. Dr. Martin mentioned this module where, we're getting the eye length measurements, but the data essentially gets plugged into these databases that are highly sophisticated and allows us to then crunch risk factor and look at progression rates. Now, the cool thing in the software that is relatively newer within the last year for those that are already using this tool, make sure you check out the new features. And so there's a color-coded scale that can put on green is normal, orange is moderate, red is treatment modification recommended. And we can also plug in specifically, say if I have a patient that I'm measuring axial length with the Myopia Master, that I start off with a certain treatment. So you mentioned the MySight earlier, and we look at that growth rate. If say it turned out it's a little faster than what we want it to be, and we decide to make a shift into another treatment, we can then identify in the software at what point we made that change with maybe added atropine or move them into ortho-K. And the software will color code all of those treatments and draw out a figure that you can share with parents, which becomes really, really cool and fun to show off in the clinic, because it's highly sophisticated and just a snap of a finger without doing any work on our end, aside from just making sure that the data's in there. Now, when it comes to sharing, value and clinical integration, that's the next section that I want to discuss with Dr. Martin. And so utilizing the tools and software to integrate myopia management into your clinic through education is another number one value of the tool. This is an example of kind of what we do in the clinic. This is one of my associates, Dr. O'Brien, posing very nicely for me for this webinar and taking a nice candid shot of how we might explain to a parent by, pulling out an eye model, but then referencing where is your child on that normative data curve. It's really, really powerful to be able to put it up on the screen. And in the next slide, there's a picture that kind of shows what the output looks like. Again, we used to make reports for parents and draw essentially with Excel kind of graphs and figures, and Dr. Martin's nodding because I can see him. I know you used to do something similar. What did you do? How did you show value for this stuff in your clinic before the Myopia Master?
I tell you, it was a big uphill battle. I mean, this goes all the way back to like flip charts back in the day when I'm like, here's a flip chart showing what's happening. I mean,
Totally.
the fact that you get this printout that just allows you to circle the stuff and talk about the things that are important and show a patient directly where our expectations are if we don't intervene. And we'll talk about that in some later slides. It just leads to such more accessible conversations and so much more successful and appreciated conversations than we were able to have before.
Love it. This next slide is one of yours, and I love it. And I really appreciate that it gives such a great outline that's kind of zooms in on some of the things that my doctors were showing on the screen to patients. It's really cool to be able to highlight these things and show the reports. In fact, we have a printer that's a color printer that's just for printing out stuff like this to give to parents. Showing value is also another way from a practice management perspective where we can actually charge for our services, because you can have all the intellect in your brain and make all these decisions, but having something to give to a patient, whether it's digital or hard copy, really adds to the value of what we're actually doing in the clinic. Now I'm going to have you flip forward 2 slides forward. And so if you go 1, 2, so here we go. So I want to just bring this back to the clinic. And so I have a case series, very short, that highlights the utility of the Myopia Master and of looking at axial length. And case number 1, so this is our first patient, 8-year-old male, Caucasian. So he's 6 years old. Prescription is Plano. And parents both have high myopia. He's starting to notice just a little bit of blurry vision, nothing too crazy. So axial length for this little guy is around 24 millimeters. So that's brother number one. So 6 years old, started off at 6 years old. Then case number two, let's go to the next one. This is our kiddo who is 10 years old. He is 8 years old, or well, 8 or 10 years old. He has a plus prescription. His axial length is a little bit longer at 25 millimeters. So let's just go to the next slide where it's a summary of what the case is. So we have our 8-year-old now. So starting off, I think it's a little confusing the way I just explained it, but starting off, we had a 6-year-old, and in 1 year he progressed. Now he's a -1 with 24 millimeter eye. And then we have a 10-year-old. He's only -1/4 with a 25 millimeter eye. So which brother, in your opinion, is higher risk is the question.
So for me, this is such an intuitive thing. You look at the 8-year-old, you're like -1, 24 millimeters. That kind of correlates. That makes sense to me. But if I look at a child who's -1/4, -1, 100 with a 25.32 eye, throws up red flags for me. That's the child I personally know is going to grow rapidly, especially going forward. Is that the way you feel about this case as well?
Well, let's check out the data. Let's see what the Myopia Master says.
Look at it.
So when we plug all the risk factors, including ethnicity, age, everything into the software, here's brother number one. So you can see that the line of the right and left eye is above his percentile. So he's more myopic than he should be for his age, because at this age, we should not have any minus prescription. Let's flip forward to the next one. And you nailed it, brother number two, based on risk factors, even though he has a higher or lower prescription, he actually is at a higher risk for faster progression based on a number of risk factors, including axial length, ethnicity, age, all these things. And so again, this is just an example of how the software is really powerful in allowing us to predict and explain to parents, why on earth would we put a kid who's a -1/4 in a myopia program? And it helps us to really show on a chart the percentile difference between the two. And to your point, Dr. Martin, on the next slide, do growth rates change with age or ethnicity? So this is a really important point. And it's kind of an interesting one because yes, growth rates do change. I don't know what you see in the clinic, but I do have parents asking all the time, where does my kid rank, against normative growth? And in this next slide, I'll show you a couple of key figures when I'm explaining axial length changes to a family. We have the ability now to pull from normative data to let somebody know if the growth is normative or if it's faster than what it would be. And essentially what we see across studies is that we do see that there is a faster growth rate and that it can be different between ethnicities. And the way that I pull some of this information into the clinic when I'm explaining, so say we measure a kid who has some progression with their program, regardless of being in myopia control or not. And, parents sometimes get a little bit shocked when there is any change. And the whole purpose of really bringing this conversation in is to make sure that we're giving proper expectations when we're setting the stage. So our goal with myopia control is to halt at some stages, but kids are going to have some level of normative growth. And what the data allows us to see is that, I used to see sometimes a kid who would progress maybe a 0.1 or a 0.2 over a year. And I'd be really hard on myself and disappointed internally with that and think, oh, shoot, it's not working. But in reality, when we look at figures like you see in this graph, showing what normative growth rates are were we not to do myopia control treatment. So for example, my 7-year-old Asian is different from a 7-year-old non-Asian. Normative growth of a myope would be anywhere from about 0.3 to 0.5 or greater if they're myopic without myopia control in the Asian population for a 7-year-old. And so when we're forming that conversation of how to address that response where we're changing by a 0.1 or 0.2, we say, well, that's actually a lot more similar to normative growth of an emmetrope approaching emmetropia. And this is actually a positive result in the myopia clinic in that the treatment is actually working really well. How do you handle those conversations when parents are disappointed?
First of all, let me say that I love this slide. There's a lot to unpack here, but that's a beautiful slide. And it is so reassuring when you're able to use a device like the Myopia Master to help explain these to parents and say, yes, your child is growing at 0.3, but we're actually doing much better than we would expect to do given the genetics of the situation and given the age. So I think that's an absolutely important thing. And much like you, I was quite hard on myself when it wasn't absolutely stop in its tracks, myopia control, right? So I think it's really important for us to remember that our goal is to lessen or flatten that curve in the long run, and that even if we're not getting as much as we want, if we're getting under this normative data, it puts us in the position to give the best success for the kids. So
Totally.
I love that.
Yeah. And and then the last piece I want to throw in on this next slide before we pass it back over to you to really kind of bring us back to the conversation piece again, because I know you are literally a world leading expert in this. I've witnessed it when you're talking teaching about it, and from hearing from some of the things that you're doing in your clinic. But remember that treatment efficacy is not linear. So this is another really cool thing when this is kind of higher level understanding of what is actually happening. And I use this all the time when I'm explaining to parents when we're analyzing axial length changes or refractive changes, whatever it is, success in the myopia clinic. Remember that the most bang for your buck is going to happen right in the first 1 to 2 years of treatment. So the change to that curve is going to be the most dramatic. And then the other thing that we know is that the myopia control treatment efficacy is not linear. So it doesn't just kind of stay the same. In fact, it's going to change and naturally decline a little bit as kids get older as well. And so when we have a patient in the clinic that has a really, really sharp curve and really, really sharp improvement that may not always be sustained, that means that we are best off to treat early. We're best off to treat aggressively early. The earlier the intervention, the better, because we have the most bang for our buck. We're going to have the most impact in that first 1 to 2 years. And then after that, kids are going to naturally slow down a little bit, but the curve can change a little bit. It's not linear. It's going to change with growth patterns too. And so it's an interesting thing to think about, and also something that we need to understand as far as success, so that we're not disappointed or overpromising to parents when we're explaining exactly how these treatments are going to work. Now, going into the next slide is going to lead into our communication discussion. And so Dr. Martin is going to lead this section, because I want to personally hear a little bit more about how you let the axial length guide your risk conversation with parents.
Yeah, so I think it's really interesting. The Myopia Master gives us such great tools. And I think it's important to remember, especially in the myopia clinic or really in any facet of your practice, that when we're talking about implementing a myopia management program, some people are more sensitive to amounts of myopia than others. Or let's take this for an example. Here's a patient that's new to your office. They're close to 14 years old, right? And they've got an eyeball that's a little long. They're maybe a minus, what are we looking at? A minus 2.5, maybe a minus 3 at the outside in that one eye. So this is a conversation that's really interesting to have. And I want you to start thinking about how you would start this conversation with a parent, because you can talk about a couple of different things here, okay? You can talk about prevention. You can talk about options. You can talk about whether the parent, I'm going to go back a slide, really is enthusiastic about embracing a myopia control program here, or a myopia management program here. I have some patients who are absolutely dead set against their child having a prescription of a -5 or -6. Other parents may be more open to that. But I think what's nice is when you can have a conversation about what are our options. Here are the options. We can do nothing. Your child's probably going to end up a -5 or a -6. We can talk about slowing it down. Can we get more outside time for your child involved? Can we talk about options for treatment? Maybe it's MySight on this particular patient, Ortho-K, likely not low-dose atropine in a 14-year-old because they're getting ready to drive, and that could be a factor for us. Another thing that's important on this slide, and this is strictly my opinion, I think the Brian Holden vision calculator slightly underreports the spread of nearsightedness in the diagram, the arrows on the right-hand side here. I think some of those studies were done pre-2020, and so I think there's actually slightly higher rates of myopia now than there were just 4 or 5 or 6 short years ago. Sheila, do you have an opinion on how the pandemic changed rates of myopia, both in amounts and rapidity?
So we know that, this goes further than just opinion, but there's evidence to say that it has changed. So we know that post-COVID, there have been reports in a couple of different articles on that the rate of change has increased, and that kids have been continuing to present with higher levels of myopia that has been progressing at a faster rate. So definitely I'm on your camp on that one.
Okay, so let's talk about this 8-year-old emmetrope. So this is another interesting conversation. So let's take a look here. We've got an 8-year-old emmetrope, not a terribly long eye, and we're really predicting this child's going to come in around a -3 in all likelihood. This is a patient that you're apt to see in your clinic, and a lot of how the parents want to handle this is based on what their concerns are for myopia, meaning that if you have a parent who's a high myope, they may look at this child and be like, hey, again, I don't want my child to be a -4 or a -5. Maybe they want to put the child in ortho K to free them from glasses and contact lenses. Maybe they want to get their child into MySight and prevent them from having a more significant prescription. I think it's important to be open to the fact that we want to control myopia, especially for the ones that are the obvious. Your child's going to be a -8, -9, -10. They're going to have a huge, long axial length measurement with all the problems. But some people want to control myopia in their children, even at some of these lower rates, like a -4, a -5, or -6. And I think it's important to let them know that if they're motivated in that direction, that may be something that you would feel comfortable with. Sheila, how would you handle a patient like this one who doesn't have a terribly long eye and probably is only going to end up a -3 or a -4? How would you handle it if the parents said they want you to do something about it?
I think that any amount of saving any amount of myopia is going to ultimately be in my opinion, would be the path to take when it's in the best interest. So for a couple of reasons, not just because we are necessarily saying that, if because we know that the rates of disease in the back of the eye go up starting at a 4 to a 5. So, that -3 endpoint is not the end of the world. However, the -3 is at a higher risk for complications compared to a lower prescription, and also the quality of life. I mean, having the ability to be able to see a little bit better in the distance for the rest of your life versus not, I would encourage treatment for sure. But I may not be super likely to do combination therapy right off the bat. I may be likely to recommend, and can you remind me again of the prescription level at that point?
Yeah, so this particular child is close to emmetropic.
Yeah, so that's a tough sell. That's a really tough sell. So in this one, I would probably take a look at the risk factors, and I would watch similar closely and just look again. Because this one in particular, if he had a long eyeball, if he was a little bit myopic already, I could put him in even like, low power spectacles and get treatment to kind of ethically do the right thing. But this one, I would just watch just a little bit longer myself.
Yeah, so on this particular one, I tabled it for the next 6 months for follow-up.
Yeah,
And
perfect.
that child should be coming back here in the next 2 to 3 months. And I'll be interested to see where they go from here. So,
I think a really important thing that I love about how you manage this case is planting the seed, because by having this conversation and educating them, even though you're not treating just yet, they're going to be ready to hit the gate running the minute that prescription changes, or if you can document axial length changes that are outside of the age norm axial length. So I love the fact that you took the time with them, didn't just blow it off for a year, even though you had thought about it in your mind, but took the time to explain it, and really keep a little bit of a closer watch at this very, very important age of fast growth.
and I think that's incredibly important. It's another reason why we like the Myopia Master so much in our myopia clinic, is because it really does open the door to these types of conversations. It really does allow us to start having these discussions early. And I have patients that come in. I think that's really important for the folks out there who are doing myopia management. Don't forget, every time you have a person who comes in who's a -5, -6, -7, whatever, or even a -4, and I'll tell them, do you have any children? They're like, well, I've got a 2.5-year-old or a 3-year-old. I tell them, we really want to see that child, at least in my office, when they're 4 going on 5 years old. Let's get some measurements. Let's take a look at it. And let's keep a close eye on them. They're likely to be nearsighted, and they're likely to be more nearsighted than you are. And I start that like literally from the first time I meet a young parent, or even if they haven't had kids yet. I'm like, well, if you have kids someday, remember that we want them not to have the big prescription you have, because I know how much of a burden that big prescription is. So I think it's important to be planting those seeds on almost every conversation you have, even with parents who have infants or a 1-year-old or a 2-year-old, because those kids are the kids we want to help later on. So,
Love.
okay. So here's an 8-year-old, first visit, no correction. This is a pretty obvious conversation, right? 8 years old, already 25, almost 26 millimeters, right? So how,
Definitely.
Sheila, we're going to jump into what I did in a moment here. But so what are you thinking you would want to talk about given this setup? So already a -3 in the right eye for all intent and purposes, already a 25.75 millimeter eyeball, which is long for the age for sure. What does that conversation look like for you?
So this patient, there's really no purpose in waiting. We would want to get going right away as quickly as we can into some kind of treatment. And my mind is looking now at lifestyle, what is going to be the best path for them. We know that when used as directed, atropine and contact lenses are going to be about approximately equal in efficacy-ish. Spectacles, according to many studies, are just as effective. We'll talk about that a little bit because I know in your practice you don't have access yet to glasses, but I'm thinking my mind is about where is this patient at in their life? What are their visual goals? What kind of sports are they doing? I know we're going to have to get them into some form of myopia treatment, myopia management treatment strategy. And it's just all about how can I craft the best path. I'm also thinking for myself is I usually will do optical therapies first. If the patient needs glasses or contacts anyways, just because that's the most obvious. And with a long eyeball like that, I'm going to be planning to look quickly early on for the need to add atropine if we want to do adjunct therapy.
Yeah, so this would be definitely a start them on a program, see them in 3 months rather than
Yeah,
4 months or
agree.
6 months,
Love.
right?
Yeah. Hey, do you put them on two therapies right off the bat ever? Or do you start with one or the other? And I want to
Well,
hear why, because I've got my own answer to that too.
yeah, so on this one, the age is 8. I would very strongly consider starting them on a peripheral defocus contact lens like the MiSight or an ortho K lens, and I probably would institute low dose atropine probably within the first 4 to 5 weeks, actually.
Yeah, I love
For me,
that.
because this one is already not in good shape, and I
Mhm.
know that if we don't do something dramatic, we're going to end up with a potential significant problem. So.
Now, one thing I love about how you answered that is still giving a little bit of a gap in starting two therapies at once, because when you use ortho-K, for example, or atropine, you can induce some blur at some distance. And if you just throw two things on at once, you don't know which of those two things is creating that aberration or that blur. So I do the same thing. And I think it's really, really important to understand what are we creating by using a treatment, and what is the visual outcome. Make sure that they have good enough vision and good enough binocular vision system with optical correction before adding atropine.
Yeah, and honestly, they also have to learn to get used to it, right? So I find it very
Totally.
difficult to start a patient doing ortho K and low dose atropine at the same time, because even though they're taking low dose atropine at night, I'm leaning towards 0.05 these days for these dramatic cases, and that's going to be blurry and difficult for them to learn. So I like to do the mechanical component, maybe
Mhm.
MiSight, maybe ortho K, and then I institute the low dose atropine after rather than the atropine first. Are you on the same page with that?
Yeah. Yeah. Oh, yeah. And then the last thing to note that I know we both would like to communicate is, according to literature, evidence-based for combination therapy is still developing. And so there are some reports of adjunct therapy being helpful. There's an absence of some evidence as well. And so, even though they act in different ways and intuitively, we would think that they would always be better to do two treatments would be better than one. Not always the case. And so just taking a look at the information and what is actually happening is helpful.
Again, this is my humble opinion. I would typically start that with something more significant.
I
But
agree completely.
there's no argument against starting them on something, waiting 90 days, and seeing what happens as
Ex-
well. But
exactly.
it kind of depends on how aggressive you are and kind of where you're at with your comfort level. So.
Agree.
So let's talk for a moment about the Myopia Master software and the proof of treatment success, because this is worth its weight in gold. I just used it this afternoon, and I love it. So what's great about the growth control within the Myopia Master software is the proof of treatment allows me to show people how we are doing. Are we flattening the curve? are we slowing things down? Are we looking at annualized growth rates that we can apply and talk about? I think that's where the magic happens for the actual control component. It's one thing to find, diagnose, and talk about a treatment plan, but we really want to know how that treatment plan is going over the course of time. So here's an example of an atropine patient, okay? So patient came into us, you can see they started out at 12 years old there, and you can see where their rapid growth was going, okay? And then you can see where we instituted the atropine, that's that green bar section right there, and you can see how it started to flatten out the situation on the growth chart for them. And what's nice about it is when you can share that data with patients, that is huge. When I can go to a patient and say, look, this is where they were headed, this is the tracking of what we've done, and this is what we're accomplishing, I think that's absolutely magic. Do you use that component as well, I assume, in everything you do, right?
Yeah, it's pretty cool to be able to highlight the different colors, and that's kind of we mentioned earlier that that's one of the beautiful things about the software is it just becomes such a nice way to tell the story and accurately tell it. And like you said, I don't know how you just worded that, but I loved it. What does it prove the treatment efficacy, right?
Yeah,
I love
because
that because it's yeah,
I don't know, I'm spending all this money, I'm spending all this time.
exactly
Is this really doing what Dr.
what
Martin said
we
to
say
do,
it's doing. Yeah,
right?
exactly.
And
Yeah,
if it's not, then I need to tell them we need to change, and here's why.
exactly.
So the other thing that just totally pleases me, and I use this constantly, is the annualized growth rate. We talked about this earlier. I used to write it down, divide it by the months, figure out how old they are, look at my charts. I was all over the place. And I would come back in between patients, and I'm scribbling notes. My staff comes in, they're presenting the next patient. I'm trying to get it all done. What's fabulous within the bounds of the Myopia Master is it gives you that annual axial growth rate of the eye, and that for me is fire. I mean, here's an example of one where the patient was fit into an ortho K, sort of a standard optic zone, probably 6 millimeters. And then they moved them over to a smaller optic zone, a myopia ortho K lens, specifically for myopia management. And you can see how there is a drop in the annualized growth rate of the eye. I mean, what a powerful tool that is to be able to tell the parent, look, see that red bar on the top there? That red bar was growing too fast. The yellow bar was where the concern lies. And now that we look at the latest readings, and we can see that the child is firmly in the green, which means we've got this one under good management. I just think that is amazing. I mean, the annualized growth rate, and I love the way the color chart is in there. It's just fantastic. Sheila, do
Yeah.
you find benefit from that as
Same,
well?
same. I couldn't say it better than you are. So.
I just love that. I love when I can say, here's where my worry is at. And you can see from the annualized growth rate, if it was up in the red, why we'd be having a conversation.
Mhm.
So here's another ortho K case, and you can see how we flattened the curvature on this one. And you can see the annualized growth rate, 0.10, 0.08. I mean, you can't ask for better than that.
It's
You really
epic.
can't. That's fantastic stuff. I
Mhm.
actually had one today with a negative annualized growth rate, which is an interesting conversation that you and I should have sometime as well. So, have you had any like that you
Yeah,
slowed
I
down?
mean, it's some there are some treatments, and because of choroidal thickening, there are some cases where you can actually get those measurements, and it's I would say slightly. I mean, I wouldn't say go because I suppose it's not artificial because it is what it is. We know the eyeball can't actually get shorter, but the wall can get a little thicker, and so that is a really interesting conversation to have. And sometimes parents will gloss over a little, but nonetheless, they're just happy because in their mind they get this beautiful report card that looks like their kid is like not only not growing but actually getting better.
Yeah, and that was my conversation with today. I'm like, and this is a parent and a child who are very driven. Child is all A's,
Very
and I'm
motivated. Yeah, that yeah.
like, not only is your child an A student, and the mom's like, yeah, I'm like, your child is like an A plus plus student, and you could see the daughter just get all excited. It was
Yeah.
fast. But anytime you can have those annualized growth rates where you can talk about them, patients really understand millimeters, and it really makes good sense for them. So, all right, so spectacle lens therapy. I'm going to hand this one to you. This is not my slide. Take it away, Sheila. What are your
This
thoughts on
is this this, I can go through just because it's really, I get asked this a lot. And, because we've had spectacle therapy in Canada for a very long time. And I believe that it still has not come to market in the US. And so we actually have people that fly in from all of your states to come and get glasses from us. And I just want to put out there what a valuable tool this is. And so for those of you that are in the US, I know there are very likely people watching from other countries outside of the US that maybe do have spectacles available. What a wonderful practice builder, because in our office, every single patient that wears contact lens should be in spectacles. If they're in soft myopia control lenses, my site, they're also going to have a pair of myopia control glasses so they can go back and forth. And it's a really powerful tool. And as you can see by some of the data, works really, really well in the myopia clinic. They are effective. Some of the things to watch out for with glasses, as you can imagine, is unlike a contact lens that follows the eye around in all gaze positions, glasses can slip down, kids can take them off at school. So those are some of the things that you just have to watch as far as compliance to make sure that the treatment is as effective as the studies show. But definitely a huge, huge thing in our practice, very good for practice building. And it's the safest option on the market. There's no chemicals in it, and it's just regular old spectacles for the purposes of the patient.
Love it. Okay. All right. Still talking a little bit about, oh, that's a duplicate slide there. We were just talking about this case earlier. This is a perfect example of winning. Okay. All right. So let's turn this over to you, Sheila. This is your slide here, and I really love this one. So what do you got for
Well,
us?
thank you. So, we want to close with enough time because I know I'm happy to stay, and so is Dr. Martin to answer some questions. And that's often where things get the most spicy and the most fun is really just diving in to answer any burning questions you might have or any other thing you want to gain from this. But just in summary, some of the ways that the use of axial length affects our clinic. So we've talked a lot about education. So that is just a no-brainer, but not just for our patients, also for our staff. Showing our staff the data and teaching them in staff meetings has really allowed us to have buy-in where when a patient calls in, staff know what to talk about. They're informed enough and educated enough that they can actually talk the right language. Using axial length adds value to the practice. It's really has become the standard of care in terms of the primary concern that we have when we're trying to control myopic progression. All of the literature out there is using that as the gold standard, and it also allows us to really differentiate between normal and abnormal growth in ways that we really couldn't before, and especially those pre-myopes. The really cool thing in the last point here on this slide is that systematic and personalized approach. I have to highlight systematic. So this is just like one and done. It's a system, it's a beast, it's AI. It can calculate things faster than we can read it. And it really allows us to shape and personalize treatments, which is extremely important in today's climate. It's a competitive market out there, and if we're not personalizing and suiting things to fit our patient needs, then we're going to get lost. And so embracing the technology is really the only way for us to keep up with the way that the world has moved, and furthermore really elevate what we're able to do in our clinics. And we want to just highlight some of the journey. So I want to share with you the path of as far as where you can start. Because not everyone starts off with a way to measure axial length. And if you're not measuring it yet, when I started off by referring for axial length to my partner down the street. It was a surgical center. Quickly got tired of that because that's really inefficient. Picked up something that was very simple, an A scan that could measure axial length. And that had its whole, it was really cool at first to be able to at least do it. But there is no question that the end result of landing at the Myopia Master along the trail has been by far the best step in the journey and getting there step by step. I don't know what you were doing before Myopia Master, but I know I personally would never want to go back, to be honest.
Yeah, we A scanned, and I would have them sit in this one chair and stare at the wall, and I'm aplanating the cornea, and it was just awful and inaccurate. And the myopia
Inaccurate. Yeah.
has been so magical with regards to tracking, with regards to presentation, with regards to practice management, with regards to profitability. It's so much easier to convert a patient to a myopia master plan or a myopia management plan when I can take the paperwork to them and say, this is what's going on, this is what we need to do, this is how we're going to fix it. And I've had patients take my myopia master stuff to another eye doctor, and then they come back and they're like, yeah, you're right, we're going to do it. I mean,
Yeah, to be like verify, go ahead and verify me. I dare
yeah,
you, because it'll be fine. Yeah.
I love that.
Yeah.
All
Now,
right.
in closing, we have two final slides. So I know this last one, basically, we wanted to just highlight how important it is, just in summary, as a practice builder. So start early conversations, easy to make sure that everybody's understanding. And we're also much more likely to not miss cases of myopic progression by actually collecting data. So in closing, we do have a few calls to action on our very last slide. And so early intervention is best. Appropriate follow-up is needed, so we use the axial length measurements to adjust treatment as needed. Evolution of best practices does require up-to-date evidence-based education, and that's where units like this and the software that it provides is really allows us to be able to do that for our patients. And ultimately, Myopia Master, it rocks. So with that, I will pass this back over to Dr. Martin to close the show for us and encourage the questions that Michelle might have for us.
Excellent. Thank you so much for spending time with me this evening, Sheila. Before we start questions, I am very
Likewise.
curious to hear what people have to say. I think we're back to seeing the screen. Michelle, you have
Thank
questions for
you. Thank you, Dr. Martin and Dr. Morrison, for that insightful presentation. Now let's move into the Q&A session. So just a quick reminder, if you have any questions, please type them into your text box on your GoToWebinar screen. Also, if you missed part of tonight's webcast, you will receive a recording of this presentation in a follow-up email. Now, let's dive into the questions. Both of you feel free to jump in, share your thoughts on these questions. I'm just going to ask them. Feel free, hop in and ask the question. So now, how do you explain to a parent when the axial length is decreasing when the child is in ortho-K? I know that you kind of addressed this a little bit when you might see axial length shortening, but how do you address it in terms of ortho-K?
Are you asking the question of when I'm treating ortho-K and the growth rate is decreasing, meaning they were at zero point 0.4 and now they're at zero point 0.2? Or do you mean an actual decrease in the length of the eye? Because we should not be seeing a decrease in the length of the eye.
Okay.
The anomaly that I spoke about today was likely choroidal thickening. So
Okay.
basically, with that particular patient, we've managed to slow them down to a standstill, and I'm not really sure if you can ascribe that to a shortening of the eye or just a thickening of the choroid. But I will tell you that studies have shown that a thickening of the choroid is suggestive that we're at a really good point with our myopia management. Sheila, what are your thoughts on that?
No, that's great. I think that's a wonderful answer to that question.
Okay. Thank you. Now, do you include the Myopia Master at all your annual visits? And if you do, at what age do you start and kind of what age do you maybe end that, or do you continue it into adulthood?
So I can start this one. And I do have a perspective. I have a colleague in Ontario who actually measures axial length on every child, any prescription, all ages. And that is not something that they charge for. That is just something that's a standard. And I love that. We are not doing that. What we do at our practice, and I'll ask Dr. Martin to explain how you do yours, is whenever we identify a patient that has risk, we have a separate fee. If we wish to measure for some reason the eye length of an adult or a hyperope or something like that, we can just do that and we'll add that onto the routine eye exam. But we do our full myopia academy workup that is separate from routine care. So when we identify a patient that is at risk or that we would like to investigate further with topography, axial length, cycloplegic refraction, we invite them back for a full visit that we do axial length at all of those visits. That's separate charges, separate time usually. Sometimes we'll book it on the same day as routine care, but usually we separate it. And then we follow and do the axial length measurement at intervals of 3 to 6 months.
So in our office, we measure basically all children under the age of 18. With Myopia Master, we don't charge for that. I will tell you that my technician sometimes is spotty on it. And if she brings me a patient who is either emmetropic or slightly nearsighted, I will make her go back and collect axial length from the Myopia Master for us. Um, I, I'm intrigued about the idea of charging specifically for Myopia Master, but what I do is I use it to find patients and then I just build the cost of that into my myopia management plan,
Yep.
because once we have them in the myopia management plan, I'm going to be charging accordingly. And without talking numbers, which I know is something that we're not allowed to do, I want to encourage people who are either in the myopia management field or are thinking about getting deeply in the myopia management field to charge for your services. You need to get paid for your expertise. You are hanging out with us on a Wednesday night listening to us talk about axial length measurement. You should charge more than the guy or gal down the street. Charge accordingly. Charge enough fee that you feel excited to do it and that you don't feel there's any resentment towards collecting the measurements you need to manage the patient properly. Does that kind of correlate?
Perfect.
Thank you for that great response. So, how often should we be measuring axial length, and does the ideal frequency change based on the child's age, how severe the myopia is, the treatment you're doing? How do you determine that?
Okay, for me, it would be yearly for everybody, and it's going to be typically 3 to 4 times a year, depending on the myopia management program and depending on history and how aggressive their myopia is. What's your take on that, Sheila?
Agreed. And usually I'm less likely to measure the older patients that have slowed down already more than twice a year. Whereas kids that are new to the program, I'm wanting to demonstrate success and also screen for the need to add adjunct therapy. So smaller kids that are fast progressors that I'm starting off with their program, I'm going to be more likely to measure them in 3 months rather in that first year. And then once we demonstrate stability and understand where we're at and they're naturally slowing anyways, past that important growth phase, then we'll slow down to twice a year instead.
Yeah, if I have a 16-year-old or a 17-year-old and I'm still doing myopia management in the way of ortho-K or something, I'm only going to measure them twice a year. But if I got an 8-year-old, man, that's every 3 to 4 months like clockwork.
Yeah.
All right, thank you. And I'm going to close out with this last question. So, when should we consider adjusting treatment, like increasing atropine concentrations based on changes in axial length? And what time frame do you look for to determine efficacy of a treatment?
I'm going to give one thing to that because there's a lot that we can speak of on that
Yeah.
point, and I will bring up the need to change based on compliance. So I will look at axial length, and and we can go into the numbers of what we may consider, to be too fast. I think it's all dependent on age for me, and it depends on what treatment they're already doing. But the time that I personally will look at to see when should we make a switch between treatments, if we're getting growth that is outside of normative growth for a particular age and demographic, then I would consider looking at, are we able to be compliant with treatments that we're using? How can we go up rather than horizontal to improve the treatment? And the reality is there's a lot of things um, that will determine success of myopia control, and a big one is compliance. And so I will make a change if I can determine that they're not able or are not being compliant with a certain treatment.
Yeah, and I think Sheila has the gist of this one as well. I'm going to make my decision based on normative data and how far outside of normative data they are, and whether or not I think they are ultimately being successful on the plan
Mm-hmm.
that I have them on. If I have a child on low dose atropine, and I'm not sure if they're getting their drops consistently, or I'm not sure if it's working as well as it should, and I can look at the normative data and say they're growing way beyond what I would expect them to be growing, given the fact that I've already instituted something, I may take that away and add another one, or I may do a combination, or I may change modalities entirely to try to figure out what we need to do. But the normative data in that annualized axial length growth rate is going to be a big factor for me on whether I
Mm-hmm.
change.
And to add to that, just because a patient doesn't do particularly well with one style or design of a contact lens doesn't mean that they won't do well with a different style or design. Everybody has their own unique fingerprint, and just like other type forms of medicine, humans will respond differently based on physiology, handling everything in different ways. And so one does not solve all. And having that kind of toolbox open to make those changes is important.
And knowing when to make those changes.
Mhm.
Because you can tell if their growth rate is exceeding your expectations, you can tell you have to do something different.
Yeah.
Yeah.
Thank you. That brings us to the end of our session. Thank you to everyone who attended and submitted questions. A special thank you to Dr. Martin and Dr. Morrison for their valuable insights and expertise. Dr. Martin, Dr. Morrison, do you have any last thoughts? you'd like to leave?
I do. I do. I'm dying to tell. So this is my public service announcement. For everyone out there who does myopia management, ask your myopia management patients if they take their cell phone to bed. If you do nothing else this whole next year than to have a conversation about telling the parents that the child's phone gets plugged in on the charger in the kitchen at bedtime, you'll save yourself about a diopter in nearsightedness on a whole range of patients. It's crazy how many kids take their phone in bed and then lay there right like this, staring at their phone and making their nearsightedness go crazy. So if you do nothing else but share that message about plugging in their phone in the kitchen and going to bed without their phone, you'll make mom and dad incredibly happy, and you'll slow nearsightedness down in a huge way. So that's my parting thought. Sheila?
Oh, that's a good one to end on. I'm happy with that too.
All right. On behalf of Oculus, we appreciate your participation and wish you all a great evening. Thank you.
Thank
Thank
you so
you.
much.